Well, welcome all. I want to thank all the participants and the panelists today. This is really an important time in global surgery. And as you'll see in just a few moments, I'm going to give a little bit of the backdrop or the background and what's happened with global surgery in the last few years and why it's particularly important to address financing for global surgery initiatives. So if we go back to just 1980, and look at what Halfdan Mahler, who was the Secretary General of the WHO at the time, said about global surgery. He made a quote which was really quite remarkable. He said, "The vast majority of the world's population has no access whatsoever to skilled surgical care, and little is being done to find a solution. I beg of you to give serious consideration to this most serious manifestation of social inequity in healthcare." And the reason that that was a rather amazing statement is, this is the first time that I know of that a world health leader linked access to global surgery and social equity. All right. Now, from a policy standpoint, it was wonderful that Halfdan Mahler made that statement, but for a number of years, not much changed in terms of policy. And if you fast forward 28 years, Jim Kim and Paul Farmer, so Jim Kim, who went on to be president of the World Bank, and Paul Farmer, who is the founder of Partners in Health, they wrote what is now a somewhat famous article, and certainly in the global surgery community, where they called, if you can see, they called global surgery the neglected stepchild of global health. And they were alluding to what Halfdan Mahler had said, which is that global surgery, OB, anesthesia, the surgical ecosystem is critically important to global health, but it was really not fully recognized, not fully incorporated into the narrative around global health. Now that was in 2008. 7 years later, things changed quite a bit. That was somewhat of a tipping point in global surgery. So to the left, this was DCP3, Disease Control Priority 3s. This was a major publication from the World Bank, 9 volumes, and the first volume was on surgery. So that's quite a statement coming from a major publication in the World Bank. The second thing that happened that year in 2015 was the publication of the Lancet. So this was a research publication in the Lancet journal that was 2 years in the making with multiple partners from around the world. And then the last thing that happened in 2015, which was really pivotal, is the World Health Organization's annual meeting called the World Health Assembly passed a resolution, WHA 6815. And you can see to the right here, strengthening emergency and essential surgical care and anesthesia as a component of universal health coverage. So this is the World Health Organization essentially passing a resolution ratifying the fact that surgery and essential surgery and anesthesia should be part of universal health coverage. So that was a major statement. Now I'd like to just spend a minute on the Lancet Commission, and that leads into our discussion on finance. So I was one of the co-chairs of the Lancet Commission, and to distill this down for everyone, 4 major things came out of the Lancet Commission. One was a vision for surgery, universal access to safe, affordable surgical anesthesia care when needed. We came up with 5 key messages, which I'll go over very briefly. 6 indicators, so 6 metrics that we felt ought to be collected for global surgery at a national level. And these have subsequently been accepted by the World Bank for their World Development Indicators section. And then the last thing, which is particularly germane to our discussion today, is this concept of surgical strategic planning. So what's come to be known as National Surgical Obstetric and Anesthesia Plans. Now this concept is a strategic plan for surgical care delivery at a national level, which must be integrated in national health priorities. And I say it that way because what we don't want is a vertical program. All right, so this is something that is supposed to be run by ministries of health, run by countries, prioritized by countries, and integrated into their national health priorities. Now I show you this because this gives you an idea of how the tide was shifting from 1980 to 2008 to 2015 to where Jim Kim actually gave 2 addresses at the Lancet Commission, one at the very beginning of the commission and then several years later at the official launch. Now the reason I showed Jim Kim is because he was important in really kind of promoting a couple of the key messages that came out of this, or really kind of behind the scenes giving us some advice on messages. So if you look at the first 3, for example, 5 billion who lack access to quality surgery and anesthesia and OB, 143 million additional procedures that are needed. The third key message was around financial risk protection. So 81 million people face catastrophic expense. Now, the last two are the ones that Jim Kim and the World Bank pushed us to think about. And one was, how could we think about surgery more as an investment? All right, it's not just kind of throwing money down the drain, but it actually helps countries, it helps health systems, it helps economies. So we had a number of modeling experts from different universities look at a 15-year period, and we asked them the question, if you made investments in global surgery, first, what would it take to bring low and middle income countries up to some type of acceptable level? And what would the economic return be? And you can see what the modelers came up with. They came up with a large number for an investment, 350 billion in low and middle income countries over 15 years. But when you look at the potential economic impact, I think that's what should get people's attention. And the last message that was literally from Jim Kim's mouth was that surgery is an indivisible, indispensable part of healthcare. And the reason that's important is because it alludes to the integrative nature of surgical care. Again, it's not a vertical thing, it's part of properly functioning healthcare systems. So what is this concept of a national surgical obstetric and anesthesia plan? Well, it is a process that looks at the key components of surgical care delivery. So workforce, service delivery, infrastructure, information management, finance, and governance. And obviously today we're going to talk really mostly about financing for this type of capacity building. Now, just to give you a little understanding of what's happened since 2015, this was the meeting during the Lancet Commission when the group said, yes, strategic planning around surgery really is an important part of healthcare delivery. We published in 2015, and you can see what happened. Several countries began the process. More countries began the process in 2018. SADC, the South African Development Community, actually passed a resolution in November of 2019 that all SADC countries should have a thoughtful strategic plan for surgical care delivery. And then you see in 2019, Nigeria came on board, the Pacific Islands as a group did, World Health Assembly had an official side event, and the Western Pacific region of the WHO added surgery to their annual regional committee meeting. Now, another thing that I wanted to have you listen to was a recording from Dr. Tedros. So the Harvard Dubai Center for Global Health Delivery had a number of meetings over the last several years. And in 2019, Dr. Tedros taped a video message for us for the beginning of this meeting. And I wanted to have you listen to it because he does a wonderful job of summarizing some of the messages from the Lancet Commission and his thinkings and feelings about how surgery should be integrated into UHC.
Lord William Itangi, Professor John Miara, Dr. Walt Johnson, colleagues, distinguished guests, ladies and gentlemen. Greetings from Geneva, and thank you for the invitation to speak to you today. And I'm really sorry I can't be with you in Dubai. As you know, surgical, obstetric, and anesthesia care is an essential part of every health system. No country can achieve universal health coverage unless its people have access to safe, timely, and affordable surgical services. 9 of the 13 targets in SDG 3 will never be achieved without improved surgical care. And yet, globally, 5 billion people and 90% of the world's poor lack that access. It's therefore vital that countries invest in surgery. WHO estimates that globally investments of $350 billion are needed between 2016 and 2030 to build appropriate surgical systems. Failing to make those investments could result in losses of more than 12 trillion US dollars. As part of WHO's transformation, we will be engaging in much more strategic policy dialogue with countries to identify health systems gaps, ensuring that all countries invest in surgery on the road to universal health coverage. Thank you for your commitment to this very important issue and for your support as we work together to promote health, keep the world safe, and serve the vulnerable. I thank you.
So I wanted to show that because I think it's important that people realize that surgery is no longer the neglected stepchild, as Jim Kim and Paul Farmer said. So people get it now. And here's a nice map that shows you the extent of how people get it, in the sense that these are the countries that have actively embarked on some type of a surgical strategic planning process for their nation. And you see the SADC community here, the Pacific Islands. So more and more every year, ministries are saying, yes, we want this. And they're starting to go through the process. And that's why financing is critical. The other thing I wanted to show you is that the Western Pacific region had their 71st annual meeting called the Regional Committee meeting. And actually global surgery was one of the 5 major themes in that meeting. So again, within the WHO system, you can see that this is gaining ground. And here's the resolution that was passed. So you can see this was from October 9th. And the resolution said that it requests the regional director, Dr. Kasai, to provide advocacy and technical support to members to implement the action framework for surgery. All right, that's a very positive statement. The other thing I'll just bring to people's attention is that we've partnered with UNITAR, the UN Institute for Training and Research, and we just recently published the National Surgical Obstetric and Anesthesia Planning Manual. And this is a manual for countries to use to help them go through the process. So it doesn't prioritize for them. It really helps them go through the process so they can establish their own priorities. And then I'll leave with this. So, 5 years ago when we were in the midst of the Lancet Commission, we framed the Lancet Commission largely on the basis of UHC and SDGs, and that's certainly valid. I think more recently we've come to understand that we also need to have one eye on what is the role of global surgery, anesthesia, and OB in pandemic preparedness and global health security. Not to say that we should COVIDize everything, and I mean that sincerely. We don't mean that every sentence with global surgery, should use the word COVID. But I think it's valuable to understand what the role of surgical infrastructure has been in the response to COVID. And then lastly, and most importantly for today, how do we finance these initiatives? Quite frankly, now we have a situation where countries are saying, yes, this is important. We understand this. You have the president of the World Bank saying that surgery is an indivisible, indispensable part of healthcare. But to turn that into a reality, it has to be financed. And so that's why we are so fortunate to have the panel today to help discuss that. And so with that, let me pull in our panelists today to help with that discussion. So how do we take what's happened over the last 20 to 30 years and what is the role of innovative financing in helping countries do this? So the first panelist is Sean Bonner-Shelvin, and he is the managing partner of Global Impact Partners and was a co-author of the Global Steering Group on Impact Investments paper on widening and deepening the global impact investment market. Sean, where do you see the potential for impacting investing in global surgery and global health more broadly?
Thank you, John. It's a pleasure to be with all of you this evening, this morning, wherever you are. So broadly, I think one of the key pivotal moments we are at is the rapid growth in the impact investment market, where I think this year's GIN market survey highlighted there's $710 billion in assets under management with an impact investment. And to really think about what are ways to mobilize that, particularly in strengthening health systems globally, in line with a lot of what Dr. Mira talked about. But a key question within this is the appropriate structures within which this takes place. And so a key focus of our firm, Global Impact Partners, has been really in how do we mobilize that flow of capital. And what I'm going to do now is briefly share a few slides in terms of what we do in this space. Ultimately, the objective of what we're doing is really to see how we can expand the fiscal space with external financing within this. It's not to say this is a panacea, a silver bullet, or replace government funding, but really is a complement to resources within this. And this is what I was mentioning earlier about the GIN's recent market survey, with $710 billion now coming into the space. What's critical though, much like a good cardiac surgeon, we're really trying to do the bypass surgery here between the blockage in the markets, where there are gaps in terms of structures, allocations, and the capital pools on one side and the needs on the other. One of the platforms we've been working on towards this is the Global Health Impact Partnership. We launched last year's GSG conference, which is a platform to deploy $1 billion over the next 5 years into a series of outcomes-based financing instruments. So outcomes-based financing is just one of several instruments in the space that's relevant, but one which we think is particularly valuable when a number of factors are present. To give you a sense of outcomes-based financing, for context, there have been actually additional projects since this, but there are now over $400 million in capital raised, with projects in over 30 countries now that have been done. And all but 2 of them that have been completed have actually repaid their capital. There are some which are still in progress where the outcomes are still not shown, but there have only been 2 sort of clear defaults. To give you a high-level concept of how this works, this is in principle one of the outcomes-based financing structures we've been looking at with Health Pals, and Professor Dash will speak next. But in this model, we're working with outcome commissioners, and an outcome commissioner is someone who bears the contingent liabilities of negative health outcomes. Those could be government health systems, they could be employee health schemes, especially where those cover lower income individuals in the community, and it could be insurers. But what it basically involves is them signing a contract to share a portion of their savings with investors, and that's held in the project special purpose vehicle. On that basis, investors fund the project special purpose vehicle to then engage service providers to go and deliver this. And broadly, in the context of some of what we've done in cardiometabolic disease, that's involving Health Pals doing precision prevention with AI. It's healthcare providers going to do community screening and smart health technologies that tie into this. And this is ultimately targeted on improving health outcomes and reducing expenditure across a range of conditions, including early cancer prevention, maternal and child health, as well as cardiometabolic disease. What's important is not to look at this specific structure and think about how to directly replicate it, but to think about the principles behind it, Dr. Mira, and where that applies in global surgery. And to me, when I look at areas like laparoscopic surgery and the ability to reduce downstream complications, aspects of maternal and child health, and better antenatal care to improve outcomes, and even certain cancer screening, all of these to me are valuable ways with which outcomes-based financing is one of several tools. But this, I want to emphasize, is only one of several tools within the space. And I think what's key as we think about ways to mobilize impact investment into strengthening global surgery is considering 4 broad questions. Firstly, who benefits? Secondly, where and where do those benefits occur? Thirdly, when do those benefits occur? And finally, how can we quantify, measure, and share those benefits when they're realized? And that's basically the approach that we broadly take in developing funding instruments, where taking this approach then lends us to be able to identify what are the most relevant instruments in funding these. And I realize I should have also introduced this at the start, but impact investment, for those who are new to the term, are basically investments made to have a direct, quantifiable, and intentional positive social and environmental impact. But this is just one perspective we have on this. This instrument is one of several that are being used in this, in addition to things like in health infrastructure, health systems funding more broadly, amongst others. But with that, Dr. Mira, I'll hand it back to you to introduce the next panelist.
Thank you, Sean. That was fantastic. I have several questions for you, but we'll circle back to that later. So next is Associate Professor Rajesh Josh, and he is a cardiologist on faculty at Stanford Medical School and the chairman of Health Pals, an AI company dedicated to using technology to create guideline-driven insights for precision prevention to close healthcare gaps. Rajesh, if you could please briefly introduce the Clint platform to our audience and share your experience in using outcomes-based financing to scale your program.
Thanks, John. It's a great honor to be able to speak with all these tremendous panelists today. So yeah, I'm Raj. I'm a preventive cardiologist at Stanford. I actually started at Stanford as a molecular imager, looking for identifying early signs of heart disease. And that led me to start a clinic at Stanford, which is the US's only dedicated cardiology clinic for preventing heart disease in South Asians who have the highest rates of heart disease in the world. And through that process, I kind of stumbled upon the fact that over half of our patients should have already been started on blood pressure, cholesterol, or even diabetes medications before they even came to see me. These were gaps in their care that directly impact outcomes, whether that's cardiovascular outcomes like heart attacks or strokes, or even pre or post-surgical outcomes. And I realized that we needed a digital solution that would identify gaps in care at an individual level and then be able to scale those across a population. And so I was able to have a tremendous co-founder, Sushant Shankar, who is a data scientist, and we built a technology platform called Clint, which is clinical intelligence. Clint is the engine of the company Health Pals that is basically giving this technology or applying it to data sets all across the world. And we've done this for now 1.7 billion patient life years of electronic health record data and also claims data. What I'll do right now is I'll give you a glimpse into what this does, so it gives you a better picture of the technology. This is an individual patient, not an actual patient, but just as a demonstration, a 49-year-old Indian woman who has a moderate risk of heart disease, 6.1%. And this is Clint, the fundamental unit of our clinical intelligence platform, where you can see all of her risk factors contributing to that moderate level of risk for a heart attack or stroke in the next 10 years. It also shows you modifiable risk factors versus fixed risk factors like ethnicity and family history, and she can have lower cholesterol, lower blood pressure, which actually have meaningful impacts on her outcomes as far as heart attacks and strokes. And she could also lose weight, but that's actually less of an impact on her overall outcomes. So this helps you prioritize as well as identify the gaps in care for any individual. Now you can do this at an individual level for any disease or outcome that you want to model, but you can then scale that to a population level. And this is actually the demo version, but it's actually running live on about 125 million patients in the US right now. So this is actually showing you gaps in care at a ZIP3 level in the US for diabetes medications, patients who don't have adequate medical management of their diabetes based off their medical records and their current medication lists. And so we can do this at a granular level, at the individual level, and then zoom out to the population level. And what we've done now is taken this to single payer as well as other forms of international health systems in low and middle income countries, India, Indonesia, Malaysia. And it's really with tremendous efforts and collaboration with Sean and Global Impact Partners that we've been able to do this, forging collaborations with state and federal governments where they are incentivized to improve the health of their constituents as well as save money and cost on very expensive bad outcomes. And as I think about, positive, measurable progress that we've made, we recently signed an agreement with the government of Telangana to roll out Clint in their Basti Dwarkana clinics, which are the inner slum clinics of Hyderabad, where we are going to be focusing on maternal or gestational diabetes and diabetes in general, on screening for cervical, breast, and oropharyngeal cancers, and also on managing hypertension. And so those are disease states that can vary based on the needs of each community, but Clint is diverse in its ability to be able to apply codified medical guidelines into the engine and apply them to real world health data, and do that instantly and provide at the point of care or at a population level that kind of perspective. We find that governments are not able to see the forest for the trees in terms of paying for prevention. And I've seen that a lot in the last 10 years that I've been at Stanford. However, the concept of impact investment has actually really helped de-risk the whole equation, where they are agreeable that they understand they pay a certain amount for healthcare for these conditions. And if they pay less because of an intervention like this, they're willing to give a component of those profits back to outside investment. And that could be through government investment organizations or even private investment. And so that's something that we work closely with Sean on to really achieve change in these global health systems.
Raj, thank you very much. That was outstanding. And if you remember, one of the domains of the National Surgical Obstetric and Anesthesia Planning was information management. So that was a fantastic example for all of us to see how you are using information management to improve care. Next, I'd like to introduce Varun Javeri. He is an officer on special duty in the CEO's office at the National Health Authority in India, leading the innovation strategy, and he focuses on supply side strengthening at the NHA. Varun, how can impact investing add value to a government health scheme such as Ayushman Bharat, particularly in cardiometabolic disease?
Thank you, Dr. Miara. Firstly, an absolute honor and pleasure for me to join this illustrious panel today. Before I come to the broader question of how innovative financing, can actually impact a robust health system, at the National Health Authority, we have designed and implemented a program which is called the Ayushman Bharat Pradhan Mantri Jan Arogya Yojana. When you were running us through the presentation, you mentioned a statistic which said that 5 billion citizens across the globe, they lack access to surgical care. Now, the scheme that we run, that is the world's largest publicly funded healthcare assurance program, which provides health coverage to 500 million citizens against catastrophic healthcare expenditure. And this forms the 40% of India's population. And when we talk about the catastrophic healthcare expenditure, we are essentially talking about the secondary and the tertiary care, which comprises most of the surgeries, which are out there. It's been a couple of years since we have been implementing this particular program. And in last 2 years, I'm happy to inform that we have provided a free treatment to more than 13 million Indian citizens. And these treatments have been worth more than 2 billion, of which 45% in terms of the absolute number, somewhere around 45% have contributed to a surgical care. Now, when we actually look at the value, we can see that the total value of this particular surgical care is around 67% of the total value of the type of claims that we have reimbursed. So, in and all, the focus of Ayushman Bharat is tremendous towards the secondary and tertiary care. At the same time, we have more than 23,000 hospitals which are there within our network, which actually provides the access to the treatment. So in and all, this is perhaps one of the strongest strides towards achieving the universal health coverage that India has made. And we are taking these strides in all three aspects when it comes to access, the quality, and the affordability of the care. So this is the program that we are running. Now, how this is linked with with the whole aspect of the innovative financing, it comes from the fact that through the Ayushman Bharat, there is such a huge demand shock. The 40% of India's population, the bottom 40% of India's population, when we look at that, the demand for their healthcare used to be around 1.5% as compared to somewhere around 5.5% of the top 40%. So huge disparity between the bottom 40 and the top 40. Now what is happening is that with this particular financial healthcare protection that we have, the government has started acting as a payer of the care, and now this is stimulating a better healthcare supply side. So in terms of getting more hospitals in the country, getting more equipments in the country, and ensuring that the citizens, the bottom 40%, can actually avail those particular services. Now, in order to augment that supply, there is a huge need for financing. When we talk about the financing, we have seen that innovative financing is one particular avenue that we want to leverage very skillfully. One of the initiative that we are taking with regard to this innovative financing is that we have actively started looking at how we can use different financing options to actually finance this particular supply of healthcare. One particular example that I want to give here is that we are trying to actively see, can we use the blended form of grant and debt capital to actually provide this particular support to the entrepreneurs, who either have innovations or who either want to build supply side infrastructure. Now, An interesting aspect of this is that we want to see if this grant component can be sourced from some of the foundation or from some of the international financial institutions, and if that grant component can actually act as a as a financial guarantee or as a first stop loss guarantee against that particular debt capital. So we are getting huge sort of interest from the financial institution to actually put in their debt capital, because they know that there is some sort of form of a guarantee through the grant capital guarantee. So in a way, the idea is that can we catalyze the supply through the increased demand that is happening through the Ayushman Bharat program. We have seen in various Indian states, Dr. Dash was giving an example of Telangana. Even in the state of Telangana, when they had launched their particular health scheme before a few years, we saw that there was a dramatic increase in the supply side healthcare infrastructure. So we want to see that with a scheme like this, which is there pan India, can this particular demand catalyze it? And if it is catalyzing it, can we provide different forms of innovative financing to actually make sure that that particular supply side can use it, and we can ensure that more hospitals and more supply side infrastructure can be built. I feel that this is perhaps one of the biggest requirement that India has, that we do not have the adequate supply side. Our doctor to patient ratio or our bed to patient ratio, that is way below than the WHO aspired ratio. So we want to see if this particular program can actually bridge that supply demand gap. So this is this is the work that we have been doing at the National Health Authority, and I can speak more about it. We are looking at different options too, but I think this is the focus that we have, and we feel that in years to come, as Shan also mentioned, that the outcome based financing, these are some of the tools that we want to actively leverage, and we want to build a strong supply side infrastructure in the country of India.
That was outstanding. Varun, thank you so much. There are several points that I want to get back to in terms of financial risk protection and also infrastructure development. Now I'd like to introduce Caitlin Medley. She is a portfolio manager for impact and responsibility investments at QBE and co-chair of the Impact Management and Measurement Community of Practice at the Responsible Investment Association of Australasia. Caitlin, QBE has committed over $1 billion to impact investing. Can you share with us what drove this commitment? Where does current interest exist? And what does an institution like QBE look for in an investable deal?
Thank you. Thank you. Look, it's such a pleasure and an honor to be with you today. Yes, so QBE set the ambition to increase our impact investments to $1 billion by 2021, and I'm pleased to say that we're on track. We're on track to do that. So to provide some context, so QBE is a general and property insurer, and we're headquartered in Australia with major operations in North America and in Europe, and operations in more than 20 globally. And in terms of the assets under management, so that's USD about 24 billion. And we have an impact investing initiative called Premiums for Good. And so this is, so effectively it's an initiative whereby a portion of insurance customer premium, which would be invested in any case, is directed towards investments that have an additional social or environmental objective. And that's at no additional cost to the customer. And part of the impetus for that is that we, that QBE felt that customers and business partners would insure where their insurance premium was doing more, and that employees would choose to work with a company where premium is invested in this way. So as premium grows, the demand for social investment grows. And since 2015, that's grown. And in 2019, we announced the ambition to grow that to $1 billion by 2021. And as I mentioned, we're on track. And we've extended that ambition also to $2 billion by 2025. And within the impact investment approach, QBE are taking, it's an institutional investor approach to impact, so that we're investing within our existing investment mandates and fiduciary obligations. And we're investing across 11 impact areas, a variety of currencies and geographies. And within the Premiums for Good pool of assets, that effectively reflects our asset allocation. So it's green, social and sustainability bonds, renewable infrastructure, impact private equity, say social property funds, and also social impact bonds, for which we have a specific commitment. So thinking about the social impact bonds or impact bonds and outcomes-based financing, we do have a specific commitment for that. And to provide some context, in 2014, the QBE board announced the intention to invest up to $100 million USD in suitable social impact investments, specifically social impact bonds and PFS across the global portfolio. And it's the transformative potential of impact bonds as evidence-based, measurable and high impact investments. And these types of public-private social sector partnerships, that was something that really resonated with our leadership, with our management team and our people. And QBE aimed to lead in support of the instrument, in support of impact bonds. And to date, we've invested in 11 SIBs in the US, in Canada, Australia, and the UK, and also in 2 social impact bond funds. So we aim to bring an institutional investor lens to these types of transactions, and particularly to bring a perspective about what's attractive for an investor such as QBE, but that is with a long-term view about the potential of these types of partnerships for social outcomes, and in order to attract other institutional investors and more capital into the space. In terms of the health context and the impact areas that we're investing in, we invest across a range of impact areas because we're interested in the support for the instrument. And so we're investing across a range of areas, such as programs that reduce children being removed from out-of-home care, substance use reduction, education, health, criminal justice, chronic and youth homelessness, as well as mental health. And so, for example, in Australia, we're invested in a social benefit bond, as they're framed in Australia. That's a mental health recovery-oriented program, which is a community support program which has peer support and residential care. But the aim is to actually reduce acute events and hospitalisation. And in Canada, we're invested in an early prevention program, Activate, which effectively is a lifestyle change and digital health program to prevent the onset of high blood pressure for pre-hypertensive people. And that was one of the first, was the first pan-Canadian social impact bond that aims to support 7,000 people. So we do see and are exploring opportunities for impact bonds in health. And certainly, sort of as has been touched on in the discussion today, you know, there's the health component provides that strong evidence base in health, the availability of data, and the potential to replicate various interventions in different locations or for different contexts with appropriate sort of local partners. And thinking about, I suppose, that investable opportunity piece, you know, those are some of the factors that we consider. And in addition to that, thinking about the evidence base for the intervention, we also consider, you know, the partners that are involved, the counterparty risk that is related to the outcomes funders, whether that's government or whether that's private sector. And importantly, the performance management approach, because that active performance management and the ability to course correct is towards achievement of outcomes is something that is an important part of impact bonds and the outcomes-based financing piece. And of course, we look at the structure of payment metrics and the alignment of parties to think about achieving impact. And it's probably fair to say also that, notwithstanding that there are already 190 impact bonds that have been issued now, that it is still a nascent area, and that in order to attract institutional capital, we would see that there's a certainly sort of a place for moderate risk with moderate returns, so that at this early stage, that the way that transactions are calibrated is with a good likelihood of return of capital, the development of track records so that we can increase investor confidence, so that looking at a moderate range of outcomes for the capital repaid and moderate returns. And certainly, as has been sort of referred to, the forms of capital protection such as first loss or blended finance structures certainly would be supportive to attract more mainstream capital into this space. And finally, as an institutional investor, certainly scale is something that we consider. So the scale of capital that can be invested is important, due to both the transaction costs and the resources required for the amount of capital that can be deployed, but also in terms of impact considerations, in terms of outcomes and the range of people that can be reached. So with that, I'll stop there, but happy to respond to any questions later.
That was fantastic. And I'm just so impressed that you're committing $2 billion by 2025. That is just remarkable. So now I'd like to introduce Marissa Leffler. Marissa is currently the Health Program Director at UBS Optimus Foundation and the former Innovation Team Leader for the Center for Accelerating Innovation and Impact at USAID. Marissa, what was the impetus for UBS Optimus to establish an impact investment allocation? And why are philanthropic investors interested in this field? And what is UBS Optimus's health focus?
Thanks, John, and thanks for having me here today. It's a wonderful topic, and very pleased to be able to discuss it with these illustrious panelists. Just to give everyone a brief introduction to UBS Optimus, in case you're not familiar. So we are part of UBS, the global wealth manager, and part of the UBS Philanthropy Services offering, which was established over the last 2 decades and built up over the last 2 decades to provide access to guidance and resources to manage our clients' philanthropic giving in both the most efficient way and ensuring that they're doing the most good. And our philanthropy services offering is based on 3 core pillars: comprehensive advice, shared insights, and execution services. In addition to our work to drive greater impact through our clients' philanthropy, we also look to use our position as a financial institution to bring more money to development, particularly private capital, and to make sure that that money is also driving impact. It's estimated that to achieve the Sustainable Development Goals will require an additional $2.5 trillion annually. And philanthropy alone can't reach that required funding scale, with an estimated only 1.5 trillion in philanthropic assets being invested annually. We also know that private markets are not reaching the most vulnerable and don't always address the most challenging problems. In addition, commercial capital generally is not invested significantly in development. And this is very dependent on effective local regulation. And often these investments are not commercially attractive. So for example, education or healthcare for the poor. And we also know that private investors require financing vehicles that have acceptable risk-return profiles. So with an estimated 280 trillion of household wealth globally, an estimated 80 million of which is available to be or discretionary funding that can be invested, we believe that innovative social finance can be used to make investments for development more attractive for this commercial capital and enable us to harness that commercial capital for impact. So I think it's important to kind of separate what we see as social finance from impact investing, because with social finance, we are really laser focused on that impact. So what we do is we link financial returns to social impact. So where there's more social impact achieved, the higher the financial returns. And by doing this, we are addressing some of the criticisms of other impact investing instruments, which are more focused on market-based financial returns, and the impact is kind of less front and center, and the extent of that impact may vary as a result. As Caitlin alluded to, the social finance market is still somewhat niche, but we're really encouraged by the continued increase in private individuals' desire to have social impact, including with their investment capital. In a recent survey by UBS in Switzerland, we found that 1/3 of the respondents said that they were willing to give up some financial return in order to have more social impact with their investments. So we're very encouraged, and we have been using thus far, trying to test two different models of this for social finance. One is what we call impact loans, and the second are development impact bonds, which are a version of what Caitlin was referring to as social impact bonds. So in social impact bonds, the government is the outcome payer. In development impact bonds, usually it's a donor who is the outcome payer. But I'll come to that in a second. So just to give you a sense of what an impact loan is, it's a pretty straightforward debt financing instrument, a loan, where we as UBS Optimists serve as the lender and are borrowing and are lending to a borrower, typically a for-profit social enterprise. And we are tying the interest rate on that loan to specific social impact metrics. So I'll give an example of a low-cost social enterprise in Kenya called Hewatele that is providing low-cost oxygen to health facilities in Kenya. And as we know, the oxygen availability gap is huge, especially in Africa. 25% of health facilities never have oxygen available, while 32% have an irregular supply. And oxygen is critical for treatment of things like childhood pneumonia, which is one of the major killers, and of course is especially critical for the provision of safe surgical care. So we see an opportunity with Hewatele if they can expand their operations to help fill that oxygen gap in Kenya. And so we've provided to them a loan that will enable them to purchase additional oxygen cylinders to maximize their production capacity and therefore to serve more facilities. And so in this case, the interest rate that we are charging on the funding that we have loaned is based on a kind of combined impact metric. One is the number of oxygen naive facilities that they're serving. So new facilities that they weren't previously reaching and didn't previously have oxygen, a regular oxygen supply, combined with distance, a metric of how far are the facilities, how far away from the production plant are the facilities that they're reaching, because we know it's often those last mile facilities that are going to have that biggest access gap. So that's just one way of tying the financial return to the social impact, although in this case it's kind of an inverse proportional relationship, whereas with development impact bonds, we're looking more at that directly proportional relationship. I think it's also important just to clarify for everyone that development impact bonds or even social impact bonds are not bonds. They're performance or results-based contracts where investors are providing the upfront capital for an organization, often a nonprofit organization, to reach its social targets. And so in the DIBs that we've been involved in, for example, that could be improving learning and getting girls into school. And so if and only if that organization reaches its targets, another entity called the outcome funder, likely, in the case of a SIB, as I was saying, is a government. In the case of a development impact bond, a donor like USAID, pays that investor back, including a predefined return. And the return is proportional to the level of social impact achieved. So again, in in that education example, the more girls that are back in school, the more children improve their learning, the higher the social impact, but also the higher the financial return for the investor. And in these structures, those social outcomes are verified by an independent evaluator, kind of like an audit, so that we all have confidence that those outcomes were actually achieved. Just to give you all an example of a development impact bond that we have designed and invested in, or co-designed and invested in health, is called the Utkarsh Development Impact Bond. It's being implemented in Rajasthan, India. And this is using, again, that private capital to fund interventions aimed at improving maternal and newborn health through improving the quality standards of small healthcare organizations in Rajasthan. So helping them to reach accreditation standards. And so we're trying to reach 360 small healthcare organizations, building their capacity to reach these accreditation standards. And then in this case, the financial return is tied to the number of facilities that have reached that accreditation standard. I think one thing that's really exciting about development impact bonds is the kind of multiplier effect of the capital. So in the case of the Utkarsh bond, for example, we only need to invest $3 million of that upfront capital with $10 million of outcomes funds in order to kind of implement the full bond. So we're using the outcome payments that are done periodically or over the course of the development impact bond to continue funding those upfront capital requirements. And so we have this nice multiplier effect of, that every dollar invested having a 3 times impact. As Caitlin mentioned, that we've seen the impact bond market grow exponentially over the last decade, and the track record is actually looking quite good. Of those that have concluded, about 60, although the numbers are always changing, only one has failed, meaning that the social impact targets were not achieved. So given that we're seeing so much interest in these mechanisms, and given that they do seem to be working fairly well, we're now looking to reach greater scale and efficiency with development impact bonds by taking a portfolio approach, by pooling the investment capital, using a blended finance vehicle that combines philanthropic capital as a first loss tranche with private investor capital that will have different return profiles based on the preferences of different potential institutional or other investors. And we're looking to build up a pipeline of development impact bonds that will be part of this portfolio, including in health. So in health, we're currently designing a primary health outcomes fund that would look at improvements in access to primary care. And we're also exploring the feasibility of a development impact bond for improving access to diagnosis and treatment for pediatric cancer. And so, some potential, I think, to use this model for safe surgery in the future. But I think there is still some kind of foundational work that needs to be done in terms of establishing some of those evidence-based interventions that have that clear causal pathway to the outcomes, and some service providers with a really strong track record of results. So I will leave it at that, and thank you.
Thank you, Marissa. Boy, this was just fantastic, and it's clear to me that an hour was not long enough. I do want to give the whole panel a chance to respond to a couple things. Since Marissa just finished up, I want to go back to Caitlin, and then I'm going to give each of them just a quick question. We're going to have to do lightning round questions here. So, Caitlin, I was so glad to hear that you're committing $2 billion by 2025. And so, if you were going to take that $1 billion, how would you design an impact bond for surgery? Because I think what you need to understand is you have a bunch of clinicians on the webinar here, and we don't fully understand what an impact bond might look like for surgery. So that's a question we'll just think about. I'll give you a second to think about that. Varun, I have a question for you. I was fascinated by your concept of debt capital and first loss capital to encourage debt capital. What would that look like in India for surgical infrastructure? And could that also be used for surgical education? Because workforce, as you mentioned, is a huge issue. Raj, I loved what you're doing around information management, and it's a really fascination of mine with the ENSO planning and how we manage data. What might that look like for surgery? You gave an example non-surgical, but do you have any thoughts about how could a country use that for surgery? And then Sean, I'm going to let you just speak for a moment at the end. But Raj, let's have you just comment for a sec.
That's a great question, and thanks for the inquiry. I think there's a lot of ways that it can be used in the surgical arena, and the first is for instance, in Telangana, one of the screening mandates is to identify by implementing the proper checklists, essentially, for these clinics, identify more individuals at earlier stages of oropharyngeal, cervical, and breast cancer. So making sure that those screenings are being done by identifying gaps in the performance of those screenings and then alerting other care teams and tertiary centers of positive findings when those findings are reported. So that's just on the sort of the upstream capture of disease. But also from a pre and post surgical management standpoint, there are desired custom protocols that any health system would want to be in place to make sure that certain patients are getting the proper preparation as well as post-operative care. And then of course, around the success of a surgery and the complications that can happen afterwards is the management of things like diabetes, hypertension, that can impact wound closure, that can impact overall outcomes. And so better management of chronic disease in that regard is always of importance. I think that there are a multitude of ways to also overlay, and one of the questions I received from one of our guests attending today alluded to this, is overlaying certain other types of geographic maps of socioeconomic status and even in water, understand where we should be looking for potentially higher incidences of these diseases. And that's something that our Clint platform is able to do and currently does in data sets where we've been lucky enough to get those different data streams integrated. And that's something where there's a big opportunity, if some of that data exists, where we can actually start to hone in on high opportunity areas for particular disease states that may be emerging, that may require surgical management or other interventions. So it's a platform that's generalizable in that way. So I think that some specific value, but also some more aspirational value there too.
That's fantastic. Thank you very much. Varun, what are your thoughts about debt capital for infrastructure and possibly workforce in surgery?
Yeah. Well, thank you, Dr. Miara. That's a very interesting question. I think, the role that we are taking as a government entity is not only of a provider or as a financier, but more that as of a facilitator. We understand that, partnerships, and that too, especially with the private sector, is extremely critical, if we want to expedite the pace of development. So, the options that we are exploring is that, can we develop public-private partnerships in, upgrading the infrastructure? And then can this particular public-private partnership get the support of innovative financing mechanism? One particular regulatory intervention that the country of India has made is that the country has recognized Ayushman Bharat hospitals and the parties who want to build this type of hospitals as a priority sector lending area. So within that, if I want to build a hospital, instead of getting a 5 crore credit, I can get a 10 crore credit. So, along with the regulatory interventions, we are also trying to see if partnerships can be forged in. One example of that is, we are trying to facilitate a partnership wherein, we can get, the private capital, that is a private debt capital from the financial institution. We can get the private, grant capital from the foundations and the international development institution. And, we are still, if you look at our role, we are still at the fence, but we are still facilitating all the stakeholders to come together. I think in this particular scenario, what the government is really trying to do is that it is trying to add a lot of credibility, and it is trying to bring a lot of stakeholders together and give them the information that this is where the gap is. We are here to help you with the regulation. We are, here to help you with the interventions. Why don't all of us come together and forge this particular partnership? One particular aspect that you mentioned with regard to the surgical education, I think that's, very, very important. And a key intervention that one of our nodal entity is trying to do is that just like how we have counties back in states, we have district, which is a smaller subunit of a state, and at every district we have a district hospital. So we are trying to see, can we upgrade those particular district hospital into medical colleges through a public-private partnership. So the idea is that, a private player can, enter into an alliance, can take over the district hospital in upgrading it, can expand the infrastructure, and at the same time also run a medical college. So what essentially is happening is that, we are trying to broaden the type of services which are provided at the district level. And at the same time, we are creating, a very strong workforce which can actually cater to those services. So I think, the time right now is to, leverage technology, is to make more partnerships, is to bring all the stakeholders together, use data as much as available, and try to, see the entire, stakeholder landscape in a very different manner. And I think that is the type of role that, we have been taking. And we feel that, through the interventions that we are doing, we will definitely make, quite a dent in the type of surgical access that India has. And I think that will propel India towards the journey of achieving universal health coverage.
That was fantastic. I love those ideas. And I'm sorry we've run over a little bit. Caitlin, I think you're going to have to bring us home. So I'm dying to hear $1 billion idea for impact bonds. How would you construct that? Is it possible?
Well, I mean, yes, I think we have seen a couple of examples, and if we think about sort of, and I guess it's a smaller case, a smaller sort of example, but for example, there is the cataract impact bond, SIB, or DIB, it's a cataract impact bond, but effectively it's so private. So I think it's philanthropic funders and sort of private capital, but largely donors are providing the capital to support both, I believe, the medical infrastructure, plus also the delivery of particular surgery. So it's amplifying the availability of that surgery for the population, and that the outcomes are paid on achieving those both numbers in terms of surgery, but also quality outcomes as well.
Okay,
so it's not simply oh, you get the numbers through, but there's actually that it's about thinking about the evidence base and the overall purpose that aiming to achieve from a social perspective. And so there's a return associated with that, and that may be simply return of capital, or it may be return of capital together with, sort of an additional component for the use of that capital for funding. But there are examples that already exist on a smaller scale, and if we think about impact bonds in relation, those examples of impact bonds, but then thinking about from a scale. Thinking from a scale perspective about how that can be applied with existing health infrastructure, and the existing sort of institutions that others have referred to, and donor agencies, that I think there's certainly a there's certainly there's certainly potential. Yes, there's certainly potential, and there's evidence. You know, there are cases already, even if they're smaller scale, but certainly there's certainly things to be able to draw on and build that case.
Well, I think you're right, and I think we're going to have to wrap it up. I would love to keep going, but I think other people, I'm sure everyone has other probably Zooms that they have to get to. But just to wrap up, you were talking about going to scale, just so that people remember. The other thing that the Lancet Commission modeled was that about 1/3 of human disease requires surgery, OB, anesthesia, the surgical ecosystem care. So, you know, in terms of taking things to scale, I think now, you know, in the global health world, people are realizing that surgery is something that can be taken to tremendous scale. So I guess we just want the global surgery community, the global health community, the impact investing community to start thinking about how do you tailor these vehicles for surgery, for safe C-sections, for fracture care, for children's care, for cancer care, et cetera. So much more on this later. I guess I want to thank everyone for calling in today. I was so impressed to see questions coming from Brazil and Cyprus and, you know, old friends from all over the planet. Stephen Dean from the Royal Australasian College in Australia, and Emmy Suzuki from the World Bank, and Pierre Theodore from J&J, all these people from all over that are interested in this topic. So thank you all for calling in, and to the panelists, I really appreciate it. A number of you were either just about to go to bed or getting up at 4 in the morning to do this. So we really appreciate everyone's hard work on this. Thank you all, and have a good day.